Gtd. I'll discuss with you the definition, incidence, pathophysiology, clinic, how is the clinical presentation and how we diagnose, and then management, and the more important follow-up and contraception and advice on the future pregnancy outcome. Now, gestational trophoblastic disease, it is a group of disorder spanning pre-malignant conditions from complete and partial moles that we called as hereditary moles to the malignant condition of invasive mole, choriocarcinoma, PSTT, and ETT, epithelioid trophoblastic tumor. So, gestational trophoblastic, it's a group of disorders, not a one disease. And the following all this comes in the GTD. Now, complete mole, partial mole with the live fetus or twin pregnancy, invasive mole, choriocarcinoma, and placental site trophoblastic tumors. Now, there is difference between the GTD and GTN. Now, let's see what is the difference. If there is an evidence of persistence of GTD after primary treatment or persistent elevation of HCG, the condition is referred as GTN. The diagnosis of GTN does not require histological confirmation. It requires only beta HCG. Now, I will give you example. If patient molar pregnancy, complete molar pregnancy, their follow-up, there's no persistence of beta HCG decline, so this is not a GTN. This is GTD. If they have persistence of the high beta HCG in the follow-up, or like choriocarcinoma, PSTT, and the other disease, if they have remaining, I am recording. Yes, tell me.
I will check my patient before 6.
Okay. I will just finish recording and then I will come to do the. Just do the medication, Jennifer.
I did everything.
Okay, I'll just finish the recording and I will come. The diagnosis of GTN does not require histological confirmation. Now, molar pregnancies are subdivided into the complete and partial mole depending on the genetic and the histological feature. Now, there is difference between the partial mole and complete mole. This is important for the interns. I'm going to discuss now the karyotyping. The partial mole, they are triploid, okay, and the complete mole are diploid. Most common is 46XX, and the karyotyping could be XXY or XXX. Diagnosis: the partial, usually they present as a miscarriage, and the complete they present as molar gestation. In the partial mole, they are small for dates, and the complete mole, they are large for dates. Thecal lutein cyst, they are rare in the partial mole, but they are 20 to 25 to 30% of the cases in the complete mole. And beta HCG is less than 100,000 and beta HCG more than 100,000. So more beta HCG, it was more stimulation and more thecal lutein cyst and more large bore dates. Medical complications are rare, but in the complete mole there are medical complications and they can occur. And subsequent GTN in the partial, it is 0.5 to 1%, and the complete mole, it's 15 to 20% more chance for subsequent GTN. And the embryo is always present, often present, and it is absent. Amnio and fetal membranes are present. In the complete, they are absent. There is villus edema, it is focal, but in the partial complete, it is widespread. Trophoblastic proliferation also focal, and in the complete, it is slight to severe. And atypia mild, and in the complete, it is marked. And P57 staining, immunostaining, it is positive in the partial mole. Now, PIH is also more common in the complete mole. It is 10 to 25%. It's rare in the partial mole. Partial mole are more common than the complete mole. As I told you, complete moles are diploid and they are androgenic in the origins. Means they are both chromosomes from the sperm father, and there's no maternal tissue. With no evidence of the fetal tissue, usually 75 to 85% as a duplication of empty sperm or hollow sperms without any genetic material. So there is duplication, and in some cases it can be dispermic fertilization. Now this is complete mole vesicles, and you cannot see the partial moles are usually triploid in origin with two sets of the paternal haploid chromosomes and one set of maternal haploid chromosomes. The incidence is 714 live births, with women from the Asia having higher incidence compared with non-Asian women. In the Asian women, it is 387. It is almost double as compared to 1 in 752. The incidence of live births after live birth is 1 at 50,000. Now, the age wise incidence, it is more common at the extremes of age. If the woman age is less than 15 years, the chance is 1 in 500, and if the woman age is more than 50 years, it's high risk. It is around 12%, 1 in 8. Normal conception to what happened in normal conception, one sperm came with 23 chromosomes and the egg diploid 23, so they make 46. What happened in the complete mole? There is one sperm and it caused duplication and two sets of the paternal, and in the partial mole two sperms came and triploidy. Now the clinical signs and symptoms of molar pregnancy. The most common presentation is irregular vaginal bleeding, 60%, and the women present with the positive pregnancy test and supporting ultrasound evidence. Less common presentation of molar pregnancy include hyperemesis, excessive uterine enlargement, hyperthyroidism, because beta HCG, it is similar with the thyroid stimulating hormone, so it stimulates thyroid, so there is sign and symptoms of hyperthyroidism. Early onset preeclampsia, because there is poor trophoblastic invasion. Placenta is deficient, so it again start the cascade for early onset preeclampsia. And abdominal distension due to thickus, gluteal cyst, or any cyst accident. Very rarely it can present with the hemoptysis and seizures due to metastatic, because there's choriocarcinoma, it went to the lung and there's tumor and the seizures. How are the molar pregnancy diagnosed? The definitive diagnosis is made on the histological examination. However, we can do pre-evacuation diagnosis by beta HCG. It will be 2 times multiple of the medians, okay, and ultrasound snowstorm appearance. The pathological features with the diagnosis of complete molar pregnancies include absence of the fetal tissue, extensive hydropic changes of the villi, and excessive trophoblast proliferation. So when you are sitting in the clinic and patient post-abortion will come and will show you after abortion placental report, and you see extensive hydropic changes and excessive trophoblast proliferation, this is just molar pregnancy. Features of partial molar pregnancy include presence of the fetal tissue, focal hydropic changes in the villi, and some excess trophoblast proliferation. Ploidy status and immunohistochemistry staining for P57. This is theca lutein cysts. They are associated with complete mole 25-30%. This is the picture. And it's very easy to diagnose. You will find snowstorm appearance and both hyperstimulated ovaries. Now, the management removal of molar pregnancy. Suction curettage is a method of choice for removal of complete molar pregnancy. Before it is suction evacuation, but now we can do the gentle curettage also. Ultrasound guidance during the removal and the curettage may be used to minimize the chance of perforation and to ensure that much tissue as possible is removed. This is according to the RCOG guideline that if ultrasound available, it should be preferably used because it will reduce the chance of the perforation and you can remove much of the tissue. And you can see the suction cannula here. Okay, so suction curettage has been performed using a 10 millimeter cannula. Okay, complete cannula, these are suction cannula we can use. There is disposable and the metallic. Cannula up to maximum of 12 millimeters is usually sufficient to evacuate all complete molar pregnancies. So suction curettage is a method of choice for the removal of partial molar, except this one we discuss for the complete molar because there is no fetal tissue. We can use suction curettage at any gestation for suction curettage. But if there is partial mole and if pregnancy is more than 15 weeks, then we can consider medical evacuation also. Suction curettage is a method of choice for removal of partial molar pregnancies, except when the size of the fetal part deters the use of suction curettage, and then medical removal can be used. Like patient, usually it is early diagnosed, patient present with more than 15 weeks, then it is difficult for suction evacuation because there are fetal parts. Then in this situation, medical curettage can be considered. It is not contraindicated, it can be considered. NTD prophylaxis is recommended following the removal of all pregnancies, and I will discuss this in the detail why. Medical removal of complete molar pregnancies should be avoided possible irrespective of the agent. Okay, because it increased the risk of requiring chemotherapy. It was 16-fold higher when the medical methods of the for the complete molar were used and when as compared to surgical removal. Avoid potent oxytocic agent because there's potential to embolize and disseminate trophoblastic tissue through the venous system, leading to respiratory distress syndrome similar to presentation amniotic fluid embolism. So when you are going to use oxytocin and there is still tissue, so the same mechanism will happen and it will travel to the lungs and will cause amniotic fluid embolism. Or even if it is not causing amniotic fluid embolism, later it can cause metastatic disease. For twin pregnancies, when there is molar pregnancy alongside a molar pregnancy, the woman had decided to terminate, or there is demise of the coexisting twin, and the size of fetal part deters the use of the suction curettage. Medical removal can be used. So if there's twin pregnancy and again the one fetus is large, you can consider medical removal. We have one case like this partial molar and it was a partial mole and it was a complete mole in the one sick and the other one was twin, and she aborted around 19 weeks, spontaneous abortion. There is a higher rate of incomplete removal with medical methods. Okay, so there is chance why we prefer surgical, because with the medical there is chance that we cannot remove completely. That's why we go for the suction. Okay, and in the medical methods what happened that uterus is contracting, there's more chance for embolization. The risk of this is increase the risk of this increasing the need for treatment for GTN is 13 to 16% with complete molar pregnancies and 0.5 to 1% with partial molar pregnancies. Women who have unrecognized molar pregnancy and undergo medical and surgical evacuation of pregnancy are at increased risk of life-threatening complications of GTN, require more surgical intervention and more risk of chemotherapy. So this is also important. Like patient is going for termination of pregnancy, she don't have ultrasound, or even she has ultrasound. Ultrasound is sensitivity in diagnosing molar pregnancy is 56%. So this unrecognized mole after abortion is 2.7%. So it is a pretty high incidence. So if there is unrecognized mole and you go for suction evacuation or medical, for example, there is risk of heavy bleeding, okay, and more chance that she will receive chemotherapy. Now, NTD prophylaxis is not required for the complete mole because there is no fetal cells. However, it is required for the partial molar pregnancies. And confirmation of the diagnosis of complete molar pregnancy may not occur after some time after the removal, which could delay the definition administration of NTD. NTD we have to give within 72 hours. We have cut off for the 17. Astropathology will take 10 days. So even if ultrasound is telling complete or partial, you give NTD. Even if guideline is telling there is complete mole, you have to give NTD because there is chance that it will turn out to be partial mole and then you will miss that time period. So according to the new guideline, ultrasound says complete mole, give. If histopathology, you get very